Islet transplantation is a procedure which is still available in the United States under clinical trials. And I've been conducting those clinical trials, testing different approaches to optimize this procedure. So let me tell you what it is and how what we offer patients. So for patients who are desperate patients with type 1 diabetes, for who has poor glucose control despite their best efforts, despite using the best technology, closed loop systems, pumps, and CGM, and having access to the best endocrinologists and guidance from them, when their glucose control is poor and their life is severely compromised, they come to us and we can offer them. Today, we can offer them whole pancreas transplant, but this procedure requires general anesthesia, major surgery, and requires to take and immunosuppression, right? Which has a toxicity. In order to minimize the side effects, we develop islet transplantation. We isolate the islets from the same cadaveric donors, deceased donors, from the pancreas of those donors. In our laboratory, we suspend the islets in the solution and we infuse those islets as minimally invasive procedure into patient liver, into patient portal vein, through the catheter placed by interventional radiologists through the skin, through the surface of the liver, under local anesthesia. So we infuse the islets. There is no need for surgery. The islets grow into the liver, they stay in the liver, and this is when they control the glucose, secreting the insulin and glucagon in optimal way. Now, based on our experience, we can reverse diabetes with islet transplantation. However, a patient may need a second infusion with islet from the second donor, since the number of the islet isolated from a single donor might not be sufficient, so patient may need a second or third infusion in order to be off insulin completely. And then the second part is the immunosuppression. We've been using the same anti-rejection medication which we use for kidney, pancreas, or heart transplant. But as we know, they require a very close monitoring in order to prevent the side effects, manage the side effects, adjust the dose. So these been the challenges related to the procedure. Therefore, we've been offering this only to highly selected patients. Now, we've been looking for a better immunosuppression with less side effects and better outcomes. And one of the medication which we came across, and we were approached by the drug manufacturer to test, it's Tegoprubart. It's the co-stimulation molecule. It's monoclonal antibody, which is infused intravenously into patient. First, more frequent, but eventually every 3 weeks. And what's important is that this medication has potential to be as effective as tacrolimus, as calcineurin inhibitor, which we've been using for 30 years, and the most effective drug. However, it has a lot of toxicities. So the hope is that this new medication, Tegoprubart, will be as effective in prevention rejection, but it will not cause the side effects which we see typically with tacrolimus, which is the nephrotoxicity, neurotoxicity, hypertension, and it's also toxic to the islets itself, causing diabetes in non-diabetic patients. So Tegoprubart. So the study has been supported by Breakthrough T1D, which is the major foundation in type 1 diabetes, by the Cure Alliance. Dr. Camilo Ricordi, it's a scientist who has been, and Dr. Norma Kenyon from University of Miami. They were testing this medication in non-human primates. They have very promising results. So they stimulate us to start the trial. We get the funding for now for 12 patients. So we will be gradually enrolling new patients. And then we started with 3, and the results were really promising. So we expanded the study for 12 patients. So these are the patients with type 1 diabetes who over the years develop hypoglycemia unawareness, and therefore they experience severe hypoglycemic episodes despite the best insulin therapy, despite using a closed loop. and then and their life is severely compromised. So these are the patients we've been enrolling so far. As every study, there are inclusion-exclusion criteria. FDA has been guiding us with those criteria. So initially, we started with the patients with A1C above 7, but seeing encouraging results, it was lowered to 6.5, at least 6.5. The kidney function needed to be relatively stable, so eGFR above 60. And then, yes, at ADA, I presented our results. So far we have 12 patients. Today, all of them are off insulin. We reverse diabetes in all of them. In 7 of them, it required only 1 transplant. In 5 of them, they require 2 islets transplant. The longest patients in follow-up is close to 2 years. And now we're planning to extend the Tegoprubart therapy for the 3rd year for this patient and the others who will follow. There were no unexpected adverse events, side effects related to the new medication, to the Tegoprubart. No side effects around the infusion. Infusion takes 1 hour in peripheral vein. No side effects during and after the infusion and otherwise. Kidney function remains stable, no hypertension. The islets function seems to be better if we transplant the same number of islets comparing when the patients were on tacrolimus, which confirm that there is no toxicity which is visible with tacrolimus. There have been no rejections, no recurrent autoimmunity, patients doing very well, no side effects. Now, this therapy we're testing in parallel with the second medication we are giving is Myfortic, is the same medication, second medication which we use in patients on tacrolimus, supportive medication. And because of this, we've been seeing neutropenia in some patients. So the white count went down, but it recovered well by lowering the dose of Myfortic. So we know this is the side effects of Myfortic. Some patient has some other type of diarrhea, which is also typical. It requires lowering the dose. So today, only 2 out of 12 patients are on a full dose, 720 milligrams twice a day of Myfortic. All other patients are on lower doses. 2 patients, we've been closely monitoring patients for opportunistic infection. One of them is CMV, cytomegalovirus. Patient didn't develop signs of the disease, but we found the rising the number of copies of the virus in the blood, so we call it viremia, in 2 patients. And 1 patient responded well by lowering the Myfortic. And the other patient developed Valsite-resistant CMV. Valsite is a medication used for prophylaxis and treatment, so required different medication, and we needed to stop the Myfortic, and patient has been recovering since. We didn't see anything else. Oh, one of the patient which developed appendicitis, the common inflammation, infection around the appendix. It was successfully treated surgically, and patient has been well. So patients doing very well, and then there is a lot of attention in social media since our patients on their own, they decide to share the outcomes and how happy they are, and there is a lot of excitement because the results are really, really much better than what we've been seeing before. It seems to be effective and less toxic. So the study continue for those 12 patients, and we will watch them longer. Now we are about to start a second study with with the same medication, Tegoprubart. It will be combined with a little bit different medication, not Myfortic, but everolimus, which is mTOR inhibitor. We hope that this combination will be even better for the patient. The study is designed for 10 more patients, but we choose on purpose patients with kidney dysfunction, GFR between 45 and 60. And because we know it's not toxic to the kidney, and we hope by reversing the diabetes, we hope to stop the progression of the kidney dysfunction, and who knows, maybe the kidney function will even improve. So that's why we decide to offer this, and the study is also sponsored by Breakthrough T1D. Now, seeing these exciting results, the company Eledon committed to continue clinical trials and organize and start the next steps of the clinical testing of tegoprubart with more patients in order to get the licensing and the license from the FDA so the drug can be approved. The problem is that islet transplantation as a procedure itself hasn't been really reimbursed and available to the patients. So in parallel, we are working on adjusting the regulations, allowing cadaveric islets transplantation to be reimbursable procedure in the United States. We work together with Breakthrough T1D, advocating to the HHS to adjust the regulations. So we hope that in parallel it will happen and the therapy will be available to patients with type 1 diabetes in the United States. So islet transplantation will be available, reimbursed, and in the meantime, tegoprubart will continue to provide effective and safe therapy to the patient and will be licensed so it can be routinely used. This is what we hope for, that this is more effective. The other advantage is that the mechanism of action is more selective, but it blocks the key element of the immune system, preventing the rejection. But also what I found helpful is that the fact that this is administered intravenously on a regular basis. It's less convenient for the patients because they need to come to us for the infusion today every 3 weeks, but there is less space for missing the dose, for suboptimal level of the medication in the blood, which happens all the time when patients take the pills, right? Then sometimes they have nausea, vomiting, diarrhea, and absorption of this medication is not optimal, which can be suboptimal, which can lead to rejection and islet dysfunction. Here we provided IV. Hopefully there is a stable level and patients so far doing excellent. It's not only islet transplantation, so answer is yes, but not only islet transplantation. In parallel, there is clinical trial with kidney transplantation, comparing directly the new tegoprubart therapy with tacrolimus, and the results are also exciting. And then the phase 3 clinical trial is in preparation. The 1-year results were comparable, but the 2-year results highlighting the advantage of tegoprubart due to better kidney function long term comparing to tacrolimus group. So yes, the tegoprubart can change the paradigm not only for islets, also for kidney, and I know there is a plan to use this for liver transplant. In parallel, there is a xenotransplantation studies, and tegoprubart is included into therapy in xenotransplantation as well. So this is very exciting. The part that it's effective and not toxic is the most exciting part. Right. So yeah, as you said, it's a small cohort, 12 patients. However, in previous studies with tacrolimus, we also been testing 10, 13 patients, then 12 patients, and then there were always some patients who at some point had suboptimal immunosuppression and they did develop the DSA. This may happen here as well, but so far so good. So this is very reassuring, and I attribute this to, as we were discussing, to the mechanism of action and the fact that this is provided IV on regular basis. Our patients do not skip any dose so far, and they tolerated this very well. And then because they tolerate it so well, they don't hesitate, right, to continue. they really appreciate the outcome because they have clear benefit of not taking insulin again. I mean, still not taking insulin and not having diabetes without much trade-off, without much side effects. When patients, based on our experience, when the patients develop side effects, then they more tend to skip the medication and trying to optimize the outcome, but this leads to the graft dysfunction and even worse outcomes. So I think the success so far is based on the mechanism, on the constant, consistent delivery and patient compliance.